This video is all about the gallbladder. And the gallbladder is this little sac that's tucked underneath the liver. So if we draw it out, here's your liver. Here is your duodenum. And tucked underneath the liver is this little sac called the gallbladder. And what does the gallbladder do? Well, your liver makes bile, and that bile will go into your gallbladder for storage and for concentration. And it'll just stay there until some food will hit your duodenum. And when food hits your duodenum, then there are special cells called your eye cells in your duodenum that release a hormone called cholecystokinin, which literally means gallbladder move. So it tells your gallbladder, hey, we need your help. And it will release that bile. Release that bile that has been storing up this whole time. And that bile breaks down fat. All right, so bile breaks down the fat and also helps us excrete things like cholesterol, copper. Then we talk about excreting copper in Wilson's disease through our bile. So copper, iron, things like that. So those are the purposes of bile, and every time you have fatty food, every time you eat those hamburgers, french fries, and the fat hits your duodenum, you'll release that CCK and you'll release some bile. And that is the function of the gallbladder, and that's the function of bile. Easy enough? Good. Now let's kind of complicate some things. That's what we like to do, right? We like to complicate some things. So let's talk about bile. We know what the function of bile is, but what is bile? Bile is this greenish fluid and is made up of things like bile acid. Bile acid comes from the breakdown of cholesterol. And the rate limiting step for making bile acid from cholesterol is cholesterol 7-alpha hydrolase. That's the rate limiting step. And it'll make that bile acid from cholesterol. And it's pretty fatty, so it's not really liquidy, yeah? And so we can make it liquidy, if that's a scientific term, by putting it onto an amino acid like glycine or taurine. I don't think you actually need to know these, but you put it onto that amino acid and it goes from a bile acid into a bile salt. And that is water soluble. Kind of like salt in chemistry, you can put it in water and it'll solubilize. So it turns into a bile salt, and bile salts make up the majority of our acid. It helps make bile nice and soluble, nice and watery, I guess you can say. Some other things that is found in bile, well, it's going to be cholesterol. It's going to be phospholipids, water and ions like calcium and all that stuff. And then bilirubin. Bilirubin is a big one. Now, what is bilirubin? Hopefully you remember bilirubin comes from red blood cells. And red blood cells, when they eventually get old and die, then the hemoglobin inside of it will get released and broken down into heme and globin. And the heme in particular becomes iron and protoporphyrin, which through a few steps become unconjugated bilirubin, or UCB. All right, so you have all that UCB from your blood cells floating around. And the thing about UCB is that it is lipid soluble, but it is not water soluble. So you don't want it to be floating around in your blood because it's not going to be soluble in your blood. It's not going to be soluble in water. It'll cause a clot, cause a block. It's not water soluble. So how we get around that is that our good friend albumin will bind UCB. And it'll take it to our liver. So here's UCB with our good friend albumin, and it'll take it to our liver. And when it goes to our liver cells, our hepatocytes, then an enzyme called uridine glucoronyl transferase or UGT, will turn unconjugated bilirubin into conjugated bilirubin. And conjugated bilirubin is now water soluble. Now it can become a liquid. And that will get incorporated into our bile. So that bile goes into our gallbladder, gets stored until fat hits our duodenum, releases CKK, and that bile will go into our intestines. Any questions there? Any questions so far? That's how it goes into our intestines. So the bile goes into our intestines, breaks down that fat, all is good. Now some bacteria will break down that conjugated bilirubin, so bacteria, and turn it into urobilinogen. Turn it into urobilinogen. And urobilinogen has a few different routes it can go. It's kind of like choose your own adventure story. It can go back into the liver, get recycled. It can go into the urine as urine. It can go into the stool as stercobilinogen. And this gives our stool this dark color. This is what turns it brown, because stercobilinogen is brown. So it has kind of this like choose its own adventures. So it can do a ton of things, but that is the pathway of bilirubin from start to finish. Now, why did I go over all this in the first place? What's the importance of this? Well, sometimes you can have increased bilirubin, and all that increased bilirubin can deposit into your body and turn your body yellow. We call that jaundice. And usually if your bilirubin levels, so jaundice equals increased bilirubin. And usually it's when you have over 2.5 milligrams per deciliter. You get so much bilirubin that it will start to deposit in your skin and turn it yellow. It will start to deposit in your sclera, turn that yellow. We call that sclericterus, because there is elastin in your sclera, and that likes to bind to bilirubin with high affinity, so it can turn your sclera yellow. And that's actually one of the first signs. So if someone comes in with yellowing eyes, you're thinking, oh, something must be up with their bilirubin. They must have high bilirubin. And we can break up that high bilirubin by whether it's unconjugated, whether it's conjugated, or whether it's both. So unconjugated, conjugated, or both. So unconjugated bilirubin, what increases that? Well, one of the big ones is hemolysis. Where do you get that unconjugated bilirubin to start with? Well, your RBCs break down, make that unconjugated bilirubin. So if you have more RBC breakdown, then you have more unconjugated bilirubin. Yeah, this will just increase. Hemolysis is a big one. It's very common in newborns because they don't really have this UGT enzyme, and so they can't conjugate it. Yeah, they can't go down this pathway, so it kind of stops. It's like a roadblock here. So unconjugated bilirubin will increase and increase and increase, and it'll cause jaundice. This is normal. Most people are just born with not enough enzyme. That's like a perfectly normal thing. We call it physiological jaundice. And it usually takes a few days for the levels to build up so high that you actually get jaundice. If it doesn't take a few days, if it's right when you're born, then you know it's not physiological, you know it's not normal. You know it's pathological. And the most common pathological cause of newborn jaundice is hemolysis, probably due to blood type incompatibility between the baby and the mother. Maybe the baby has a different blood type, or maybe the baby is Rh positive in the blood and the mother is Rh negative and is the second baby. So, all right, blood group incompatibility. Blood group incompatible. And you'll know because, like I said, it's immediate, so it's within 24 hours, and you'll know because it's Coombs test positive. So you know there's some sort of antibody attack. The treatment for this is phototherapy. Phototherapy turns unconjugated bilirubin to something else. It turns it into a water-soluble form, and you can pee it out. Notice I said it turned it into something else. Notice I didn't say it turned it into conjugated bilirubin. That's a trick question. It does not turn it into conjugated bilirubin. Does not. Only the enzyme can do that, right? You're not giving the patient an enzyme, you're just turning on a light. So it does not turn into conjugated bilirubin. It turns it into something else. You gotta know that. So it turns it into something that is water soluble. All right. These are all causes. You can have hereditary causes. Hereditary, like Gallbladder's. Gallbladder's, again, it's kind of like physiological jaundice. You just have a deficiency in the enzyme. So mostly asymptomatic. You get jaundice on and off your life, but usually asymptomatic. So I'll just start low UGT, asymptomatic. Something that isn't asymptomatic is Crigler in a jar. Crigler in a jar. This is due to absent or near absent UGT. This is so low UGT that is no longer asymptomatic. You're gonna have problems. So, all right, absent or near absent. Or near absent UGT. All right, and there are a couple types. Type 1 is the most severe, and these patients unfortunately die usually within a few years. So type 1 is most severe. Type 2 is less severe. It's even less severe if the patient's taking phenobarbital for whatever reason, or you try and give them phenobarbital. A question I've seen about it is like a mother was taking phenobarbital and they said, what is that protective against? It's protective against Crigler in a jar. Why does phenobarbital help? No one really knows, but it seems to increase these UGT levels. Increase the synthesis of UGT. And that's the problem, right? You don't have enough UGT. So you can increase the synthesis of UGT. You kind of alleviate that. All right, you kind of alleviate that. Now, unconjugated bilirubin. These are all causes of unconjugated bilirubin, with Crigler in the jar being the worst of them. When you have unconjugated bilirubin, I said it's not water soluble, but I did say it was lipid soluble. That's important because that makes it very, very dangerous. It can't dissolve in your blood, but it can dissolve in other things that are lipid soluble, like your blood-brain barrier. It can diffuse into your blood-brain barrier. And when it diffuses into your blood-brain barrier, it can deposit in your basal ganglia, it can deposit in your cerebellum and cause something called kernicterus. And kernicterus has a high mortality rate, high death rate. History will give it away. There'll be a newborn that's yellow, but it's doing all right, and then all of a sudden they take a dive, they start getting lethargic, high-pitched cry, signs of neurodeficits, they have kernicterus. And again, there's a high mortality rate, and if you biopsy the brain, you can literally see the yellow bilirubin deposited in the brain. All right, so UCB can cause kernicterus because it is lipid soluble across the blood-brain barrier. These are all causes of increased unconjugated bilirubin. Now let's talk about what can cause conjugated bilirubin. Conjugated bilirubin. So just remind me of the pathway. We said that red blood cells die, create unconjugated bilirubin. That gets bound to albumin and transports it to your liver, right? UGT will then turn that unconjugated bilirubin to conjugated bilirubin, incorporate it into bile. And when you need to, you'll release that bile in here. All right, so what causes conjugated bilirubin? Well, it's usually due to a disruption of excretion, so you can't excrete it. Yeah, so it happens after you've conjugated it, it's set in bile, everything's nice and good. Well, if you can't excrete it, then conjugated bilirubin in bile will increase. Yeah, and it'll build up and build up and build up, and it'll back up so much that it'll deposit in your skin. You'll get jaundice. However, because it's not just bilirubin deposited in your skin, you also have bile deposited in your skin. You have more signs, more symptoms than unconjugated bilirubin. You'll have the jaundice, but you'll also have pruritus from the buildup of bile salts in your skin. You'll have cholesterol built up in your skin because that was found in bile. So you'll have things like xanthomas, cholesterolemia. And if the bile can't get out into the gut and digest fat, then you'll have steatorrhea, you'll have malabsorption. So way more symptoms than our previous talk on increased unconjugated bilirubin. All right, so way more symptoms. Now, what can cause this block? Well, anything can cause this block. You can have gallstones, which we'll talk about. You can have sclerosis and fibrosis of the duct, which we'll talk about. You can have cancer. You can have pancreatic cancer that will block this. We're going to talk about pancreatic cancer in the later videos, but very classic. Pancreatic cancer will block this duct and cause painless jaundice. You can have a parasite like Kernicterus sinensis. That's commonly referred to as a liver fluke, and that they call it the liver fluke because it likes to go into your gallbladder, go into your liver because it likes to eat bile, and when it travels up there, it destroys your ducts, so you can't drain anymore. So you block that excretion. All these cause increased conjugated bilirubin. All right. Some hereditary causes of inability to excrete bile is going to be things like Dubin-Johnson. You're going to have it backed up. You're going to have it backed up, and it'll actually start to pigment your liver and turn your liver black. Liver black. You can have rotor. Rotor is the exact same thing. You can't excrete it, but it's a little bit milder. It's so mild that your liver doesn't turn any color. So liver normal, but all these have increased conjugated bilirubin. All right. Now just a little aside on bilirubin. Now I want to get into our talk on gallbladder pathology, including stones and sclerosis. So those are our two main topics, stones and sclerosis. So gallstones, it's going to be our first talk, gallstones. And these are basically stones that come from bile. Stones that come from bile. So just a recap of what bile is made out of. It's made out of bile, acid, and salts. Made up of cholesterol, phospholipids, water and ions, and bilirubin. Gallstones come usually because you have too much cholesterol or too much bilirubin, and they kind of precipitate out of that liquid, out of that bile, and becomes a stone. Some risk factors will be anything that increases this cholesterol or increases bilirubin. So let's talk about cholesterol first. Old age, because it seems to have because you seem to have a decreased metabolism. Fatty diet, or being obese because you have increased cholesterol. Estrogen, because it also seems to increase cholesterol and causes stasis of your gallbladder. Doesn't really excrete as much. Certain medications seem to increase cholesterol, like fibrates. Native Americans are at increased risk. Haven't really found out why, but it's commonly asked. Crohn's, why is Crohn's at increased risk? Because in Crohn's, commonly affects different parts of your GIT, but like I said, Crohn's affects your ileum the most. And in your ileum, you reabsorb bile salts, bile acid, and these help make bile more soluble, more watery. And if you can't reabsorb that, then bile becomes more thick, more sludgy. And that sludge is a precursor to getting stones. So Crohn's, you can't reabsorb bile salts. That gets knocked out. All right. Bilirubin, you can increase it from hemolysis, or any chronic hemolysis can increase this. In first aid, I think they teach a memory aid to remember the risk factors of gallstones. It's like 40, fat, fertile, female. Don't remember that. That's like so crude. What they're trying to say is 40 because it's old age, fat because obesity increases cholesterol, and then the female fertile thing is just estrogen. All right, so all these are just risk factors for gallstones. And you can have gallstones of cholesterol and bilirubin. Cholesterol stones are called cholesterol stones. Cholesterol stones are usually radiolucent because they're made of cholesterol. Some of them are radio-opaque, but most of them are radiolucent. Bilirubin stones are called pigmented stones because bilirubin has color, so it's pigmented. It is usually radio-opaque because it likes to bind to ions in the bile, like calcium, so it can be radio-opaque. And they are usually black in color. Sometimes, if you have these stones lying around for too long, you have stasis, and bacteria will start to nibble on these stones and turn it from black to brown. So if they say black stones, it's the bilirubin. If they say brown stones, then it's bilirubin stones that have been sitting around too long and bacteria is starting to eat it. You're at increased risk of these brown stones if you have IV nutrition. Why is that? Why is that? Can you think of why? Here's your liver, here's your duodenum, here's your gallbladder. If you have IV nutrition, then does anything ever go into your duodenum? No. And so nothing ever goes into your duodenum, nothing ever triggers your gallbladder to release bile, so you have stasis. And if you have stasis, you can have bacteria eating those stones, and you can have increased risk of brown stones. Got it? Good. Now, how common are stones? Stones are pretty common. A lot of people have them, and they're usually asymptomatic. Yeah, they kind of just sit in your gallbladder. But sometimes those stones can come out. Yeah, sometimes they can come out and can cause an obstruction. And every time you eat food, especially a fatty meal, then it'll release CCK and tell your gallbladder to contract. And it'll contract against that stone. You get pain. Upper right quadrant pain. Right upper quadrant pain. After meal, especially a fatty meal. All right, that's like the classic presentation. So then you're thinking of, oh, maybe they have a stone. Now, how can you diagnose it? You can do an ultrasound, see that stone. You can do some fancy tests like HIDA or ERCP. HIDA, the full name will be in my notes. HIDA, you inject some radio labeled thing into the vein and it'll drain into the liver. And then eventually it should drain out into the bile ducts and into the duodenum. If you have a block, then you'll see that radio label go into the liver, go into your gallbladder, go into the duct, and then stop short. And then you know, oh, there's a block. ERCP, you put a scope in the duodenum and you spray up. You spray up and then see if there's a block. All right, so those are just fancy ways of looking for a block. And if there is a block, then you take the gallbladder out. All right. Some complications of gallstones. Sorry, complications. Anytime you have a block, anytime you have stasis, you can have an infection. We call that cholecystitis. What's the physical finding signs of cholecystitis? It's Murphy's sign. Remember, Murphy's sign is when you palpate your gallbladder and you ask them to take a deep breath, and they'll stop because it hurts too much. Why does it hurt when they take a deep breath? Well, when you take a deep breath, your diaphragm will flatten. Your lungs will expand and inflate, and you'll take a deep breath. Well, when your diaphragm flattens, it'll push your gallbladder down against that hand, and that'll hurt. So you'll ask them to take a deep breath, and the diaphragm will flatten, and then it'll cause pain. All right, so you get Murphy's sign. Murphy's sign. Other complications? That stone can dislodge and go into your gut. All right, it can dislodge and go into your gut and can cause an obstruction. We call that gallstone ileus. All right, one of the main areas that causes obstruction is the ileocecal valve. Again, you're going from a very small ileum to a larger cecum, and there's like a little sphincter, this little opening that you can get caught. Ileocecal valve. See if I can think of a question, how they might ask it. They'll talk about someone that gets right upper quadrant pain every time they eat. Maybe they're obese, maybe they're older. and they're getting this right upper quadrant pain every time they eat. Then a couple weeks later, they realized it kind of went away because the stones dislodged. And now all of a sudden they're getting bloating, they're getting obstipation, constipation, they're getting colicky pain from this obstruction. What happened? They got a gallstone ileus, okay? Another complication, that stone can rip a hole right through your biliary tree. And then when it rips a hole, it causes a fistula. And you can always tell there's a fistula because there's going to be air in the biliary tree. Dead giveaway had a lot of questions on it. They might even show you an image of air in the biliary tree, say nothing more, you know there's a hole, there's a fistula. All right, got a lot of questions on this, so make sure you know it well. And then one of the most feared complications, chronic inflammation, can cause destruction and calcification of your gallbladder. And you can see this calcification. It starts to make your gallbladder look white, look kind of like a porcelain gallbladder. We call it porcelain gallbladder. Porcelain gallbladder. And even if it's asymptomatic, you take it out. Because that chronic inflammation, that chronic turnover, what does that predispose you to? Cancer. Adenocarcinoma. Because we're dealing with glandular secreting epithelium. So you can get adenocarcinoma of your gallbladder. And adenocarcinoma of the gallbladder usually has a very poor prognosis, so you don't even risk it. You see that porcelain gallbladder, that white looking gallbladder on imaging, and they ask you, what do you do? Take it out. All right. That is all about stones. Let's talk about sclerosis. Sclerosis. Now, sclerosis can be secondary to chronic inflammation and stones. You keep damaging the area, then you'll start to get fibrotic tissue and get sclerosis. And when you get sclerosis, you can't really excrete as well. All right. Sclerosis. However, you can also have autoimmune causes of sclerosis. And there are two types. There's primary biliary cirrhosis, and there is primary sclerosing cholangitis. And they love these two because they look very similar, and they want you to be able to differentiate between the two. Primary biliary cirrhosis affects the bile ducts in your liver. And like most autoimmune condition, usually affects women. They're at higher risk of autoimmune conditions. And they'll give you a perfectly healthy woman who maybe has a history of some autoimmune condition, maybe type 1 diabetes, maybe lupus, and then all of a sudden starts to develop things like jaundice. And they may ask you, okay, what do you think might be going on? So primary biliary cirrhosis should be in a differential. So our history of autoimmune. They might ask you what labs you want to order. Antimitochondrial antibody, or AMA. That's a big lab that you must know. There's only one drug that's been approved for this, and it is ursodiol. Ursodiol is just a bile acid that seems to make bile a little bit more watery, a little bit more soluble, make it kind of flow a little easier, even if you're having this kind of sclerosis, this tightening. So it makes it flow a little bit easier, and also seems to modulate immune function. So it kind of reduces that autoimmune destruction. So ursodiol is a big one that you should know. Now, how do we tell this apart from this? Primary sclerosing cholangitis, we've already talked about. We've already talked about in our IBD video. So it's associated with IBD. So I'll give you a history of someone with IBD, and then all of a sudden start to develop jaundice. All right, that's a dead giveaway. That's not even close. These two are not even close. So we have a history of IBD, and they might ask you, okay, that's cool. What are some lab findings you might look for? You'll see increased IgM, because I said it's autoimmune. The increased IgM might be due to that autoimmune attack. And then one more, hopefully you remember, I said it was P-ANCA positive. Now, the sclerosis of primary sclerosing cholangitis is a little bit unique. It is a duct. you'll have sclerosis like this. We call it onion skinning. But then it'll kind of spare an area, and then you'll have a little bit more down here, and it'll spare an area, and then a little bit more down here, and it'll spare an area. And grossly, it looks kind of like beading. Yeah, you have kind of these beads, so beading. That's just another tip, a little hint, if you're struggling to find out what it is in the ecosystem, okay? So they'll talk about onion skin and talk about beading. And that is the pathology of the gallbladder. That does it for the liver and the gallbladder. Next, we'll talk about the pancreas. Hope you enjoyed the video. Thanks.